Okay, so we are going to go through the digestive system anatomy for lab this week. And so I'm using the lab outline that you have posted to Moodle, and that's what we're going to be talking through. So I also wanted to let you know that we'll talk about some structures on this video, but then I also have several videos of the models that we have in the lab that I've talked through. So I'm actually pointing out these structures on the models. So make sure you take a look at that as well. So to start off with, we can divide up the digestive system into two big picture categories. So we've got upper digestive structures, and then we've got lower digestive structures. So we're going to start with the upper structures, and we're going to start here with the oral cavity. So some of this is going to sound familiar because we've talked about this in the respiratory system, but we're going to look at it in a little different way and definitely pull in some more of the digestive structures here too. So in terms of the mouth or oral cavity, if we look here, this is what we're seeing. This would be oral cavity here represented on this sagittal plane view. So some structures that we have specifically here are going to be the palate, and that's going to form this structure right here. So this is going to be the roof of the mouth and the floor of the nasal cavity. So it's important to remember that the anterior aspect of the palate is called the hard palate or the bony palate, and that's because it's formed from bone. And then the posterior aspect of the palate, so back here, is going to be the soft palate because it's soft tissue, it's not bony. And then we've got our little uvula hanging off the back here, which is going to prevent food that enters our oral cavity from taking a little turn up into our nasal cavity, although sometimes it happens. So we also have the tongue, which we can see here in cross section. That's going to be this big muscle here, and so basically it's located on the floor of the mouth, and it's skeletal muscle fibers going in all these different directions, and they're kind of bundled together. And so what's happening in the oral cavity with all of these structures is mechanical breakdown of food. We manipulate it in our mouth, and we also start some chemical digestion, and that brings me to the next slide here. We start the process of chemical digestion in the mouth through salivary glands. And salivary glands release saliva, and one of the components of saliva is salivary amylase, which amylase is an enzyme that works on starchy food. It starts to break down starches in the mouth. So that actually starts the process of chemical digestion. And we've got three salivary glands that are important. One is the parotid salivary gland, and that's going to be this large gland here. And if you look at this, it's going to be just anterior to your ear. We've got the sublingual salivary gland. So sublingual means under the tongue, and it's going to be this salivary gland here. If you lift your tongue up, it's going to be right underneath that. And then our third type of salivary gland is the submandibular salivary gland, and that's going to be this gland right here. And so basically, if they've resected the bone here, but if you palpate your mandible and you go just inside of that, just medial to your mandible, that's where your submandibular salivary gland would be on each side. So all three of those are important in releasing saliva. They're going to use the saliva to help form the food that you eat into what's called a bolus of food, and it helps to clean your mouth. And also saliva contains amylase, which begins the chemical digestion of starches in your mouth. We also have teeth. So teeth play a big role in mechanical breakdown of food. So if we look at teeth, we can break it down into two sets of teeth. You've got your primary teeth, which are your baby teeth that you get when you're little. They start at about 6 months old, coming in, and then they eventually fall out, and your permanent teeth will come in after that. So you have 32 total teeth, and they are classified in our mouth according to the way that they're shaped and the types of functions that they do. So we have the first class are going to be incisors. And so these are going to be these first kind of 4 teeth here. And so we basically got 2 central incisors. So this is going to be a central incisor. This is a central incisor. And then we are going to have 2 lateral incisors. So lateral incisor, lateral incisor. And so these guys are pretty sharp. You know, if you feel them on the top, they kind of have a sharp edge. And so these are going to be good for cutting your food, biting away pieces. Okay. If we move just posterior to those incisors, we have these teeth here. These are called your canines. So you've got 1 canine on the right side. I'm imagining this is like the roof of the mouth. It would be the same on the bottom too. They're the same, but this would be the right side of the top of the mouth, and then this would be the left side of the top of the mouth. And so canines on either side. So you're going to have 2 canines on the top, and then you would have 2 on the bottom as well. And again, they're pretty sharp. So if you feel your canines, they have kind of a sharp, pointy edge to them, so they're going to be important with cutting as well. Then we've got what we call premolars. So we've got 2 premolars on each side. So we're going to have a first premolar and a second premolar on one side, and then a first premolar and a second premolar on the other side. Okay, so that's going to be those guys. And these teeth are also called bicuspids. So 4 premolars or bicuspids on the bottom, and then 4 on the top as well. Okay, and then we get to the back, the teeth all the way in the back. And so these are going to be our molars. These are the teeth that are really flat on the top. And so if you can kind of picture them, those flat surfaces kind of grind and crush your food in the back of your mouth. We have 3 molars in the mouth. So these are going to be the teeth all the way in the back. So 3 on this side and 3 on this side. And so we label these as first molar, second molar, and third molar. And our third molar is very commonly referred to as your wisdom tooth. Okay, so some of you guys probably have had your wisdom tooth or wisdom teeth come in. Maybe you've had issues with them, you've had to get them pulled out. I was actually reading a book over spring break, and it was talking about some forensic anthropology, and it was saying how actually more and more people are now being born without that third molar, that wisdom tooth, because we just don't use them anymore. We don't need to really grind our food like we used to, so they're actually kind of, you know, being basically like bred out of us. We don't have them as much anymore, so it's kind of interesting. All right, so there's all your different types of teeth, and again, it's the same for the top and bottom. They mirror each other, so they're all going to be the same, whether you're looking at the top or the bottom of your mouth. Okay, which leads us to our last structure when we talk about our upper digestive structure, and that is the pharynx. And so that's going to be this general region here. And we know already from our respiratory system that we can divide the pharynx into nasopharynx, which really would not be technically part of the digestive system, because nasopharynx should just contain air. It really shouldn't contain food, although sometimes it does, but nasopharynx should be just air traveling through there. But as we go down more distally, we have oropharynx, which is going to be the posterior part of the oral cavity, and then laryngopharynx. And these structures, or oropharynx really is going to be common passageway between food and air down to the laryngopharynx, and then we're going to actually divide off. So food would continue down the esophagus, air would continue down the trachea anteriorly, heading to the lungs. Okay, and that brings us to the beginning of our lower digestive structures. So we start here with our esophagus. So esophagus is here. It's this long muscular tube that travels down from our pharynx all the way down to the stomach. And what's kind of interesting with this is that it's a muscular tube, but it's basically collapsed unless there's a bolus of food that travels down it. So it's flat unless you've got something that you're eating and you're swallowing it and it's traveling down your esophagus. That is very different from your trachea. If you remember from the respiratory information, our trachea has those tracheal cartilages that hold the trachea open to maintain a patent airway so that we can have air moving in and out all the time. Esophagus is not like that. So it's basically like a tube. If there's nothing in it, it's flat and not open all the time. So we have the movement of peristalsis that occurs in the esophagus, and that's those rhythmic contractions of the smooth muscle to help propel the food down your esophagus. We have a couple different sphincters that are part of the esophagus, and if you remember what a sphincter is, it's going to be a thickening of smooth muscle in an area so it controls flow going through that area. So we're going to have an upper esophageal sphincter, basically at the connection of the pharynx and the esophagus, and that's going to control flow as we swallow. It's going to control food entering the esophagus, and then we're also going to have a sphincter at the very bottom of the esophagus where it joins into the stomach, and we call that our lower esophageal sphincter. It's also called the cardiac sphincter, and it's also called the gastroesophageal sphincter. So you gotta love it when anatomists give multiple names to the same structure, but they're all the same thing. They just have a couple different names. I do also want to point out, you can see in this image how we have diaphragm, and the esophagus does pierce through the diaphragm, just like several other structures do, like the aorta. We talked about that. And similar to how the aorta travels through the aortic hiatus, the esophagus travels through an esophageal hiatus, which is going to be a hole in the diaphragm where the esophagus is going to travel through. Okay, and this brings me to an interesting thing here. What we have, we talked about that lower esophageal sphincter. Well, there's some people and some patients that esophageal sphincter doesn't do a great job of closing up when the stomach is full of food, and so some of the juices, some of the gastric juices can actually flow back up into the esophagus, and we call that reflux, or also GERD, gastroesophageal reflux disease. And so this happens. This is, a pretty common thing that patients will relate to you. And like we're going to talk about, the contents of your stomach are pretty acidic. They've got a pH of about 2, and so if they do travel back up into the esophagus, it can burn and irritate the lining of your esophagus, which is not a good thing. Okay, so some parts of the stomach. That's next on our list of lower digestive organs. So here is where our esophagus is coming down and joining into the stomach. So food's going to travel this way. So here's showing our cardiac sphincter. That's that thickening of smooth muscle there that's going to control flow going from esophagus into the stomach. Cardiac sphincter, otherwise known as lower esophageal sphincter, otherwise known as gastroesophageal sphincter. Okay. If you look at the stomach, this is the way the stomach's shaped. The first part that we come to here is kind of this dome shape on the top, and we call that the fundus. That's going to be this dome here. This main part of the stomach is called the body of the stomach. Okay. This interior part here, just as we've kind of entered the stomach, is called the cardia of the stomach. And that's basically just on the other side of that cardiac sphincter. So that's why we call that the cardiac sphincter. This is the cardia. We've got this small curve on the kind of the superior part of the stomach, and that's our lesser curvature. And then we've got this larger curve kind of on the bottom of the stomach here, and this is our greater curvature. And then as we head to the other end, food's going to travel this way through our stomach. And as we head to this end, we get to an area here where the stomach kind of starts to narrow, and we call that the pylorus. Okay? And actually, the part where it narrows and we're heading into this next sphincter would be called the antrum. And so you might see that listed in different textbooks or images, but a lot of times you'll see that as the pyloric antrim, and that's just the narrowing part going from pylorus kind of heading out towards this pyloric sphincter, which is going to be this sphincter here. And the pyloric sphincter is going to control flow going from stomach into this part here, which is going to be the small intestines. Okay. We also have the rugae, which are these folds within the stomach. I think I've got, yeah. So this shows you really nicely rugae inside the stomach. If you open the stomach up, it's got all these folds inside of it, and that basically just tells you how much the stomach can distend. So it can distend to hold up to like 4 liters of food. It's not that big all the time, but when you fill it up, it has the capability of distension, and that's because of those rugae in the stomach. So the stomach does have 3 layers of muscle, and we talk about that in lecture, but it's got longitudinal, circular muscle, and oblique muscle. So we've got these muscle fibers, running in all these different directions that are going to be responsible for all this churning in the stomach. It's going to change our food, our consistency of food, into what's called chyme. And so we also are going to start the chemical process of digestion by secreting pepsin, okay, which in the presence of hydrochloric acid, pepsinogen converts to pepsin and begins breakdown of proteins. The presence of hydrochloric acid also means that the pH of our stomach is pretty acidic. It's about 2. And so we have this mucosal lining of the stomach where we have cells that secrete mucus to help protect that interior lining of the stomach from that really acidic gastric juice. Okay. In terms of mechanical digestion, we do have, because of these layers of muscle in the stomach, we do have quite a bit of mechanical digestion going on. We've got a lot of churning of the stomach, and so that's happening as well to create that chyme. And those processes are going on, but despite all of that, we don't have a lot of substances that are actually absorbed through the stomach. So the only thing that we're really absorbing into our body from our stomach is alcohol and aspirin. So not really any nutrients being absorbed at this point. Okay, let's see. I did want to point this out. This is called a hiatal hernia, and this is something too that you may see in your patients. They may tell you that they have a hiatal hernia. A lot of people walking around with hiatal hernias don't even know it. But I just wanted to point this out. This is esophagus coming down, joining into stomach. This is your diaphragm. And so basically we talked about how the esophagus pierces through the diaphragm at that hiatus. And typically it kind of closes things off. It helps that gastroesophageal sphincter, because that sphincter is not really, really great at being a sphincter. It's more of like a physiological sphincter. So it needs some help. It doesn't have a lot of muscle tone to help it out. So it's helped by that small hole through the diaphragm. But in some cases, that hole in the diaphragm becomes large and weak. And so what happens is part of the stomach actually herniates above the diaphragm. So you end up with this little pocket of stomach that herniates above the level of the diaphragm. And it was kind of interesting because a couple years ago we had a cadaver that had this. And so it almost looked like he had two stomachs, because he had the esophagus coming down. He had this little part of his stomach that was herniated above the diaphragm, and then the rest of his stomach was below the diaphragm. But this can lead to reflux. So a lot of patients have hiatal hernia. They don't commonly treat it with surgery unless it's really bad. They usually just treat it with medication, so like Nexium or something like that will help to treat symptoms of reflux because of a hiatal hernia. Okay, and then I did want to talk about a couple other things. This is actually one of my favorite. I just think this is such an interesting structure that we see in the abdominal cavity. This is the greater omentum. And so this is otherwise known as a fatty apron. So if you see this, it basically is like this fatty tissue. It's really thin, and it's got these pockets of fat, and it basically drapes over the small intestines. And it's kind of interesting. One of the things that it does is it can wall off areas of infection in the abdominal pelvic cavity, because look at all of this. All of these structures are here, and they're all crammed in there together. And so if you were to have an infection in one area, it could easily spread to the rest of the abdominal pelvic cavity, and you could end up becoming septic, which can be life-threatening. So one of the protections that we have against that is this greater omentum, and it can help to wall off areas of infection if they happen in the abdominal cavity. So here's another view. This is showing you the greater omentum, which is basically going to drape from the greater curvature of the stomach down and cover the small intestines. And then we also, because we have a greater omentum, I'm sure you already guessed that we have a lesser omentum. And we do. And so here it is. Here's our lesser omentum. And it's going to go from the lesser curvature of the stomach up to the bottom part of the liver. So it's just a little bit smaller, and it basically helps to support the structures in the abdominal cavity, namely the stomach. It kind of anchors it to the bottom of the liver. Okay, so that's omentum. Okay, which brings us to small intestines. So small intestines are going to be the structures that we head to next after we come out of the stomach. And small intestines are important because most of our digestion happens here. Most of our chemical digestion happens in the small intestines. And we have 3 different regions of the small intestines. We start with duodenum, which is going to be the first region, then jejunum, then ileum. Okay. We have some adaptations within the small intestines that help to increase nutrient reabsorption. So one of these is called plica circularis. I noted this in your handout. Plica circularis are basically folds circular folds within the intestines, and it increases surface area, and it also slows down movement of chyme as it's traveling through the small intestines so that we have time to reabsorb substances. We also have presence of microvilli with brush border enzymes that are going to help break down the food that we eat, and we also have villi that are there to help with mobility of chyme throughout the intestines. Okay, when we come to the end of the small intestines, we have, this is going to be the end of our small intestines. This is the ileum, and we have this small sphincter where the ileum joins into the large intestines. This is going to be starting the large intestines here. Okay, this little pouch at the bottom here, which is part of the large intestines, is called the cecum. And so this valve controlling flow moving from ileum into cecum is called the Ileocecal Valve. So I have that listed on your handout as well. Should be on there. Ileocecal Valve. Okay, and here it is. Ileocecal valve. So basically joining the end of the small intestines and the beginning of the large intestines here. Okay, it is notable that this is the area of the appendix. The appendix is this little lymphoid organ that's hanging off the bottom of the cecum, and basically it helps to contain or trap bacteria that you may ingest in your food, so it offers us protection, but there are also cases where that appendix can get kind of twisted on itself, and feces from the large intestines can get trapped in there, and it can become inflamed and infected, and so we call that appendicitis. And this is what it looks like. Here's a little appendix from an endoscopy procedure where they'll just go in and clip that appendix, hopefully before it ruptures. I also want to point out, just because it's interesting, if you ever have a patient come into you with right-sided lower quadrant pain, it could be indicative of appendicitis. And so the way to assess for that would be, there's a point. It's called McBurney's point. And it's basically, if you draw a line between your belly button and your anterior superior iliac spine, which was a landmark that we learned in the skeletal system, if you draw a line between those two and you bisect it, push into that spot, this is called McBurney's point, and then release, and we call that rebound pain. And so in a patient who has rebound pain in that McBurney's point, it may be indicative of appendicitis. So just a little clinical note there. Okay, so after the small intestines, we're going to enter the large intestines, and we also call that the colon. So they are synonymous, they mean the same thing. And if we look at, we've got different sections of the large intestines. So mostly what's happening in the large intestines is just reabsorption of water. So at this point, all of our nutrients have been reabsorbed. So the grand majority of nutrients are reabsorbed in the small intestines. So basically the role of the large intestines is just to reabsorb water, because we want to hold on to as much water as possible. So at this point, our food stuff is going to travel through our cecum, which is the first part of our large intestines. It's going to keep traveling up through our ascending colon, which is going to travel up the body. We're going to go across the transverse colon, down the descending colon. Then we kind of hit these curves here. We call this our sigmoid colon. And then we're going to start heading down through the rectum, and then finally out through the anus here at the bottom. So we do have some curves in our large intestines. You can see here between ascending colon and transverse colon, we kind of take a bend here, and we call these flexures. Okay, so this flexure on the right, I know this isn't the best slide in the world, but this is called the hepatic flexure because it's right underneath the liver on the right side of the body. So this is going to be our hepatic flexure. And then as we come across transverse colon and we start heading down the descending colon, this is our splenic flexure because it's going to be right underneath the spleen on the left side of the body. So we do have those bends in the large intestines. Okay. A couple other structures that we have associated with the large intestines are the Mezzo Colon and the Mesentery. So mesentery is basically peritoneum that you find throughout the small intestines, and it houses blood vessels. So you can see these blood vessels here. It's going to have some fat associated with it as well. But if you remember, we talked about when we have blood vessels, we talked about superior mesenteric artery. And when we found them in cadaver lab and you spread those intestines out, you could see those vessels embedded within that membrane. That is mesentery. So mesentery is going to be the structure that the blood vessels kind of reside in. And then the mesocolon is going to be this structure here. It's we have a transverse mesocolon here, and then we're going to have mesocolon that attaches to other parts of the colon, and it basically anchors the intestines to the posterior body wall. So again, it helps to provide some structure to the large intestines. So mesocolon is responsible for anchoring the colon to the posterior body wall to provide some structure. Okay, I wanted to point out just a couple other things with the large intestines. One is going to be Tinea coli, which is basically this line. If you look at the large intestines, you always see this kind of white line going through it, and that is a band of smooth muscle that travels along the length of the large intestines, and it basically cinches up the large intestines into like these pockets of intestines, and we call those pockets of intestines Hofstra. So like this little pocket here, this little pocket here, this little pocket here, those are all called Hofstra, and that's how large intestines, are arranged because they get cinched up with that Tinea coli. The last thing with intestines, which I don't think I have a good picture of it. There should be pictures in your book, but these are it's called Epiploic Appendages. I apologize, I don't have a good picture of it. And these are basically like these little fat droplets that hang off the large intestines. So you may have recalled seeing these in cadaver lab, but they're basically little kind of little pockets of peritoneum that are filled with fat, and nobody knows what they do. I've never been able to find a function for them, but all of our cadavers have had them. So little pockets of fat there. Okay, and moving on, we're going to come to our accessory muscles of digestion, accessory organs of digestion. And the first one is going to be our liver. And liver makes bile for us, and that is important for digestion of fats. It helps to emulsify fat, so it takes big fat droplets and breaks it down into smaller little fat droplets. Liver has a couple structures that are important. One is the falciform ligament, which is going to be this ligament here, and it basically divides the liver into a left lobe of the liver and then a right lobe of the liver. So that's falciform ligament. It also attaches to the anterior body wall, and it helps to anchor the liver in place. So as you can see, we've got several different structures that help provide support for our digestive organs. And then we also have this little ligament that's going to hang off the bottom of our liver. And this is called the ligamentum teres, or otherwise known as the round ligament. This is actually a remnant from fetal circulation. This is part of the umbilical vein that was carrying blood from the placenta back up into the baby and then to the baby's or the fetus's heart. And it actually travels through the liver. And after the baby's born, it stops becoming a blood vessel and just basically becomes a ligament. And that's what the ligamentum teres or round ligament is. Okay. Our next, gallbladder. Let's do gallbladder. Okay. Our next accessory organ of digestion is going to be gallbladder, and that's basically, here it's tucked right underneath the liver and kind of behind it. And gallbladder is kind of interesting because it's like this small muscular sac. And so bile is made by the liver, but it's actually stored in the gallbladder. And then it's released in response to hormones. The primary hormone for that is going to be cholecystokinin, or CCK, tells the gallbladder to release its stored bile. And then we also have the pancreas, which is going to be here. Okay, it kind of lays or lies behind the stomach, kind of horizontally. And pancreas is important because it's going to release pancreatic juice, which contains lots of enzymes that help us to break down all the food that we eat. And it also contains bicarb, which is going to increase the pH, and it makes the pancreatic juice much more alkaline. So it's going to have a pH of about 7. So if we compare that to the pH of the stomach, which we know is about 2, as food moves from the stomach into the small intestines, now we get released this pancreatic juice that's going to travel into the small intestines, and it's going to take that initial pH of 2 and bring it up to 7 so that we don't burn the whole inside of our small intestines. So the way that we have all of this released, we've got bile from the liver, we've got bile being stored in the gallbladder, and we've got pancreatic juice from the pancreas, and it all needs to be able to get into the small intestines. And so how does it do that? Well, it does it through this series of ducts. And so if we look at our ducts here, we've got our right and left hepatic ducts of the liver, which are here and here, and they're going to join to form a common hepatic duct. And so that's going to be here, common hepatic duct, coming from the liver. Now we're also going to have a duct coming from the gallbladder, and we call that the cystic duct. So gallbladder, again, it's going to store the bile for us, and it's like a little muscular sac. So when it's stimulated by CCK to contract and release its stored bile, it's going to send its bile out through the cystic duct, which is going to join in with this common hepatic duct to create a common bile duct. Okay? And that's going to travel down through here. Now, that common bile duct is also going to join with this pancreatic duct here, which is going to secrete pancreatic juice from the pancreas. And all of that is going to be dumped out into the small intestines. If you see this little hole right here, this is called the hepatopancreatic sphincter, otherwise known as sphincter of Oddi. So you're going to see that. You're going to see kind of both names listed, so you should know both of those. But that's how we have bile and pancreatic juices secreted into the duodenum through that hepatopancreatic sphincter or sphincter of Oddi. You'll also see this ampulla and that's basically like the enlarged part of the duct at the end of the duct. So, couple different names, in there. Don't get too worried about the details, but just know that at that um, hepatopancreatic sphincter or sphincter of Oddi is where we have release of bile and pancreatic juices into the duodenum. Okay, I think that's it.